everyone. Good morning, good afternoon, good evening, whatever time it is in your part of the world. So we are doing this talk from Kolkata, India, and I think it's being simultaneously sent to Africa as well as Harvard in the USA. Now, my topic for today is to talk about damage control orthopedics and how to practice damage control orthopedics in an unequal world. Now, when we talk about an unequal world, we are talking about unequal resources. Now, in the ideal world, what would happen if we had a major trauma? The paramedics would scoop the patient and run and go to a good center immediately, and hopefully they would reach within the golden hour. There the ATLS protocol will kick in, which would be in 5 parts with the primary survey and resuscitation, the standard A, B, C, D, E. Then there would be a secondary survey and assessment. Then if the patient was really bad, they would go to the operating theater where they would have some kind of surgery and then be shifted to the intensive care department. And finally, at a later date, rehabilitation would be done. Now, in an operating theater, in an ideal situation, most of the injuries will be managed by early total care, and the on-call team would take the patient, arrange everything, and fix all the fractures rapidly. So does it sound simple to you? For this ideal scenario to work, there are certain criteria which must be met. You have to have trained paramedics. You have to have an ambulance available, which is quickly able to get to the accident site. The patient should arrive at the center quickly within the golden hour, ideally, or perhaps within the golden half day. The patient should either have the financial resources to pay for treatment, or he or she should be eligible for the necessary treatment with some sort of an insurance policy. The ATLS trained, well-equipped emergency should be available for him immediately. There should be a well-equipped OT with an orthopedic surgeon standing on call, and this service has to be available round the clock. In addition, there should be adequate blood for transfusions. Now, we all know that cross-matching takes several hours. All implants should be autoclaved and ready to be used. There should be a C-arm, there should be an orthopedic table, there should be an OT space and an OT slot available around the clock, an intensive care bed available to be used, and again, trained intensive care personnel. So the question is, can we provide this level of service across the world uniformly? And the answer is no. Who can provide this service? With countries which have high GDP and financial resources, which are more than their needs, resources which match the population being served. They have high literacy levels, fast transport systems, straight run trauma programs usually, and good quality medical facilities. So this is a picture, and it will show you the map of the world with the GDP per capita, and you can see the green areas are the ones which qualify for the kind of care I just discussed, and then there are the yellow areas which are maybe a step behind. Also, they also have a lot of good facilities, while the bit in the middle, the red and the pink ones, they are the ones who are struggling with resource crunch. And I am from India, so it is one of the lighter shades of red. So we have a lot of problems when we deal with major trauma. Now, this is the world literacy rate map. And you can see again, there are parts which have high literacy, the dark areas. And then again, if you look at the center of the map, we can again see that right in the middle, there is a problem. The colors are not quite up to the mark. Now let's discuss my country, India, because I know it will be relevant to this meeting in Africa. We have a population of 1.4 billion, an urban-rural ratio about 30 to 70, and 7% of our population is extremely poor, though 22% are poor, but perhaps not as poor as the other 7%. The per capita income nominal in 2010 was about 2,000 rupees, which is less than $5 a day. But right now you can say it's about 6,390 with purchasing power parity, which is about 3 times higher. We have about 1.5 lakh road traffic deaths every year. And if you look at the collision rates and compare it with London, Delhi has a collision rate of about 40:1. And the collision rates of automobiles in India per hour has been going up steadily as we have been industrializing. It was 13 in 2008, and perhaps it has gone right up to 17 in 2019. Now, let me discuss some important Indian statistics because I think they are quite relevant. While we account for 1% of the world's vehicles, we have 6% of RTA deaths. The economic cost to our nation was about 10 billion in near the turn of the millennium. It is now close to 40 billion in 2021, which works out to almost 1.5% of the GDP. The number of allopathic doctors is, allopathic means Western trained doctors, is about 1.3 million. That was the figure in 2022. That works out to about 1 physician for 1350 patients. Registered nurses are about the same, 1 in 1400. And the number of hospital beds available, about 0.5 per 1,000 population. So these figures, some of them have been improving. I will show you the comparison charts. So the private sector is a major player in our country, still accounting for 80% of all the health expenditure because the government spending on health is not very high. This includes the formal and unorganized sector, which also plays a leading role. Now, if we look at the number of registered doctors per 100,000 population, we can see here that the green areas, they are doing well because they're higher than what is recommended by the WHO. The WHO has recommended 100 doctors for 100,000 patients. So these are more than 100, the green areas. But if you look at the heart of the country, again, you will see that the rates are not so good. And some of them right in the middle are pretty bad, nearly 37 and 48. So they have catching up to do. And if you look at mortality due to RTA in India, if you look at 2017, then we can see that the red areas in the middle have high mortality, right in the center of the country, whereas the parts in the periphery, they are slightly better off. Now, we have to remember two things. Mortality is not just about health infrastructure, but it also correlates with road speeds, because as we know, the kinetic energy at a particular area works out to half mv squared, which v is the velocity of the vehicle. So if you have better roads, better infrastructure, and bad traffic rules, and people don't wear helmets and they don't use seat belts, then you're looking at a much more mortality. And I think you can say that these are the areas which are more industrialized and their mortality rates are rising. Now, in India, we have excellent tertiary care centers in most of the urban areas. These are in the metro cities, the tier 2 and the tier 3 cities. But remember, most of the polytrauma happens on highways. Usually a truck or a motorcyclist is involved. And I'll show you that data when I discuss the surgical audit we have performed. But most of the polytraumas do not reach a proper center within the golden hour. They get some kind of treatment, but very often this treatment is either inadequate or inappropriate. So they either, some of them, if they're very serious, they might die or they are moribund by the time they reach a higher center. One of the main causes of this morbid state of arrival is a full-blown ARDS or an ARDS in evolution. And this is the famous graph from the ATLS manual. You know, there are the trimodal peaks of trauma. So the first peak is when the very bad accidents where patients die on the spot. The second one is those who can be saved if they arrive at a tertiary trauma center. These are the patients who would benefit from the golden hour. And the final peak is those who die in the intensive care of sepsis after several weeks. And this group again would benefit if these patients can be treated early. Now let's gradually move on to the subject for this evening, which is the history of the damage control orthopedics and how it is relevant through the treatment of polytrauma. Let us briefly look at the history. Prior to the 1950s, routine operative stabilization of long bones was not done in polytrauma because there was fear of fat embolism. But gradually there was a lot of papers from Pape and Mueller and others. And then in the 70s, they started doing a lot of early stabilization, especially of the femoral fractures with nails. And they found that there was a lot of improvement. So this went on for a while, and then everything became early total care. Patients were starting to have their fractures fixed in one go. And 1989 was actually the golden era of ETC. And I remember because I was a postgraduate student in the University of Vienna, which was a part of this ETC movement, and they were doing fractures every night. They would get all these very badly smashed up patients and fix all the bones at night in one go. And it seemed to represent a great leap forward by leading to early reduction of pain, early mobilization, reduced complications, which were all these complications. It was felt that they were associated with bed rest. And this was, much of the work on this was done by Larry Bone, who published these papers in 1989. However, in the 1990s, things started changing, and it was found that in a certain group of patients, those who were polytraumatized, had severe hypovolemia, a high injury severity score, or those who had chest trauma, who were young patients in the 20 to 30 age group, these are the patients who were not doing very well. And it was found that the reamed intramedullary nail, especially the femoral nail, was provoking ARDS. It was causing multi-organ dysfunctional syndrome, and it was actually causing harm rather than good. So at that point, a concept developed which was very radical, and the concept was that it was called damage control surgery, and for us it was damage control orthopedics. And this started initially with the general surgeons who were dealing with penetrating abdominal or thoracic trauma. And gradually this was moved on to femoral fractures, and this was a terminology borrowed from American naval military warfare, in which multiple patients were more likely to die from intraoperative metabolic intraoperative interventions rather than from the injury itself. And this changed the philosophy, and doctors started treating polytrauma by taking into account the metabolic state of the patient. And with damage control orthopedics, we started to learn to prioritize our treatment when dealing with a severe injured patient. And to remember that a patient is not just equal to a set of x-rays or a set of broken bones which need to be fixed. So there was the entire concept moved from anatomical fixation to treatment of physiology, from thinking about the patient, considering the comorbidities, looking at all the different aspects of treating these patients. And in here, one of the biggest things was that the nail was found to be the provocator of ARDS. So patients started having an external fixator put in instead of the nail. And then later on, these patients were medically treated until they were fit for surgery, and at a later date, a definitive surgery by way of a secondary procedure, the external fixator was converted to a nail. And those who did not have the damage control surgery had usually died from a lethal triad of hypovolemia, coagulopathy, acidosis, which leads to ARDS or MODS. And once it is established, very difficult to control. And so the decision was taken that a minimal amount of life-saving surgery was done. The patient was transferred to critical care where metabolic insults were corrected. And finally, the patient was given definitive care at a later stage. Now, let's just discuss what is ARDS. It's a acute respiratory distress syndrome, which is an acute severe injury to both lungs, and it is characterized by severe shortness of breath, which requires mechanical ventilation and is associated with respiratory failure. It is not a disease, but a final common pathway of events which leads to a bad outcome. You can see from here, day 1, things don't look too bad. Day 2, you can see one of the lungs has already turned white. And then on day 3, there's practically a whiteout of both sides of the lung with a very small area, which is where the exchange of oxygen is taking place. And the cause of ARDS is multifactorial, but some of the important causes in orthopedics are either direct injury to the chest or aspiration, smoke, toxic fumes, indirect limb trauma, and which is also can be associated with massive blood transfusion, a degree of sepsis, fat embolism, and those patients who smoke and abuse alcohol are particularly at risk. So during ARDS, some damaged alveoli collapse, others start filling with fluid and inflammatory exudate. The alveoli cannot absorb oxygen or get rid of the carbon dioxide because they are full of inflammatory cells. Gradually, fibrosis happens, which further interferes with gaseous interchange. And this has been discussed, and we're going to discuss the models of DCO. The model is a 2-hit model. The first hit is the extent and the type of trauma, where the original injury to the patient. The second hit, and this is most important, it's the extent and timing of the surgical intervention. So if the surgical intervention is not done appropriately or is done too quickly or too much is done, then it imposes a further burden on the biological reserve of the patient. And this is something which the surgeon can modify. It's in the hands of the surgeon. And while the first hit cannot be controlled, the second hit is in his hands, and he can use it to modify the result, the outcome of the surgery. And this is the basis. So if you look at the current Western model of DCO, you can see there's trauma and then there's surgery, the first hit, which is out of our control, and the second hit, which we can control, and therefore we can time it in such a way so that the patient does not end up dying. But now here is where we come to DCO in low resources, the model. That's why we need to, this is what we need to understand today, is that in a country like India or parts of Africa or other parts of the world, often the 2-hit model does not hold. So you have trauma and then you have very poor quality initial treatment. So you have another hit. So first hit, second hit, and then you have the surgery, which is the third hit. So instead of 3 hits, you actually, instead of 2 hits, you end up having 3 hits. And the third hit factors which I have identified are the poor initial management of the patient, poor biological reserves, by which I mean comorbidities. It could be a delay in presentation. There could be a delay in availability of funds which can hold up treatment, or you can have a hospital which does not have all the facilities under one roof, or you can have an illiterate patient who does not understand. So I think you can understand why I started this talk by talking about resources and literacy and GDP, etc., etc. So these are the third hit factors. And we have realized, so if we want to cure our patients, the way we can do it is you have trauma, then you have the third hit. Patient comes to the hospital, you stabilize the patient first, then you do a little bit of surgery, then you stabilize the patient medically, again do a bit of surgery, again stabilize, again surgery. So I repeat, trauma, third hit, these are out of your hands. But the rest is in your hands, stabilization and a little bit of surgery. So you do your surgery gradually, you don't do everything in one go. You split the surgical sessions, and we've split it right up to 7 sessions, sometimes with a mean of 3.3 in our model. And we have often done surgery up to 19 days after the surgery which was required early, but we have delayed it till 19 days with a mean of nearly 11 days in order to make sure that our patient survives. So this is an example. So this is the sort of damage control work you might have to do. This is like a pelvic clamp where you might have to use to stop abdominal or pelvic bleeding. So in our surgery, what we do is, these are the principles we follow. You operate when the patient's condition is optimum. Do not rush, but you do not delay unnecessarily. So you make sure your patient is metabolically stable, and only then do you operate. You also do not fix more than 2 bones in one go. And definitely do not nail 2 femurs in one go, because you will lose the patient. I have lost the patient, and I have learned my lesson on one occasion. So make sure that you do not do too much in one go. And if you're doing something like a free flap for an open wound, then that should be a completely separate session. You should not combine it with any other session, because free flaps often take a long time. Now, the other modifications we have done is that we try to admit patients directly to ITU or HDU if possible, under the joint care of a surgeon and an intensivist. So sometimes we put X-fixes in unstable fracture straight away, but at other times, if the fracture is not very unstable, we can take the help of traction, orthosis, splints, etc. We do physio as soon as the patient is able to tolerate it. Sometimes this is done in the breaks in between surgery. We also try to keep costs down, and we counsel the patients, those patients who can understand, and definitely to the patient party who are often illiterate and need to understand this. In between, the breaks between surgery are dealt with in a different way. We use the space to correct fluid, electrolyte, acid-base nutritional imbalances. We try to achieve the endpoints of resuscitation, such as stable hemodynamics, such as pulse, respiration, temperature, blood pressure, urine output. We need to have stable oxygen saturations, good blood gases, and bring the coagulation parameters within acceptable limits. And of course, early mobilization, even if all the fractures are not fixed. So if you've been able to fix the femur with a nail and the tibia is still broken, the other side is okay, then you can put a back slab, you can put a plaster and try to get the patient standing. So this is an audit from our hospital. It was done in the early part of the millennium, and I just want to show you to give an idea. So these are the trauma admissions we had in 1 year, in the year 2002 to 2003, 464. And they had various types of operations, which were involved nearly 284 operations. All types of different kinds of surgery were done. And 1 in 5 had a ITU admission straight away. Now, this is the slide I want to show you. What types of injuries do these patients have? Well, most of them had two-wheeler accidents. That was the largest group, or they were, you can see that these three, the patient, either they were driving a two-wheeler, or they were sitting at the back of a two-wheeler, or they were hit by a two-wheeler, or they were hit by a car. So this is the big group of patients which we dealt with. They comprise nearly 2/3 of our patients. And we then looked at a study protocol, and we looked at all the major trauma we dealt with in 5 years, and we dealt with nearly, we operated on many cases, but those who had polytrauma, who had either involvement of multiple systems or severe musculoskeletal trauma, or both, with at least 24 hours delay after trauma, we put them all together, and we found that 61 of them qualified on inclusion criteria. Now, 19 of them had only multiple fractures all over the body. 20 of them had different systems involved, and 22 of them had both. They had both multiple fractures and they had multiple system involvement. And out of these 61 patients, 55 were moribund on arriving. Remember, they came 24 hours after they were injured, having received little treatment in the periphery. And 8 of them had ARDS right on admission. So you can see the ARDS process had already started, and they had various types of surgery, major surgery, most of them, and a lot of minor surgery. This was the sort of breakup of sex-wise, age-wise, but you can see here, this is the slide which I will direct you. You see the ISS scores were not very high. So you can see that normally in the West, the group 35 to 50, that would would probably qualify for damage control measures, but you can see here that we had to do damage control for patients who had a much lower ISS score, because those who had a high ISS score and did not receive much treatment for 24 hours must have died. So they did not come to us. So those who came were actually patients who, if they had been treated earlier, would have perhaps not ended up requiring damage control, but did require it because of the nature of the delay and the lack of resources which they faced. So looking at the results, we were able to save 60 out of 61 of our patients. 51 of our 61 patients actually resumed normal lives, but those who had severe spinal or head injuries, of course, could not. Now, the 8 patients who had ARDS prior to the first operation, they were also saved, but we had 1 ARDS after surgery, and he was in fact the only patient we could not save. So our model of DCO differs quite significant from the West, and this is the model I'm trying to tell you about. In this model, we actually have 3 hits instead of 2, and the third hit is as important as the other 2. The next thing is that we use DCO for a lower threshold of injury, so for a lower ISS. The third thing is we use a lot of invasive, non-invasive techniques and aggressive physio. We use X-fixes, but not exclusively, and our treatment also continues into rehabilitation. So if we look at the 3-hit model versus the 2-hit model, in an ideal world, we can all follow the 2-hit model, but in the non-ideal world where many of us live in, we don't think the 2-hit model really is the real correct model of damage control orthopedics. We feel our model is much more realistic, as it encompasses about 70% of all of humanity. And we have shown that with this model, we can reduce our mortality as well as mortality. However, it is fair to say that this is an empirical thought which has worked, but the real test of the pudding would be to actually measure the interleukin levels in polytrauma where there have been delays. But that's a difficult project to do, but we are working on it. Now I'm going to discuss two cases, 2 problems cases which you can understand. And these are cases which were treated at that point because they were subsequently published in one journal. So I just want to show you this case because it's quite interesting. So we had a 45-year-old truck driver who fell off a hill with his truck, and he presented to us 4 to 5 days after the injury with quadriplegia. The cervical injury had been missed, and it was found to have a burst C5 with a cord contusion. He also had bilateral tibial comminuted fractures. Now, naturally, the people who had seen him had actually picked up the fractures of the tibia, but they had missed the fact that he had quadriplegia. He was also in spinal shock when he came to us. So these were the fractures of the tibia, you can see badly comminuted. And this was the fracture of the cervical spine. You can see here C5 has burst open. We have here an MRI. So the management, initially he had a resus, and then after treatment of spinal shock, we waited till the patient stabilized. There was a problem with funds, so we waited. Some funds were arranged by us. And then on day 9, we did anterior spinal fixation. And then that's it, sent him back to ITU. And then day 11, again, we turned him around and again fixed his posterior spine. And these 2 surgeries were actually not done by me, but they were done by my spinal surgical colleague. And then on day 14, I fixed both of the tibias. Now, as I said, this is from an earlier series. So we fixed both the long bones, but today I would perhaps fix the tibias one at a time because I don't put in 2 nails together most of the time nowadays. You can see here that the 2 levels of spinal fixation, anterior and posterior, and the 2 tibial nails which we did over here. And then, of course, we put him in a wheelchair and we took the help of the truckers union to help rehabilitate the patient. And this patient was still alive 1 year after discharge, but then subsequently lost to follow-up. The second case case of ARDS, this was a 23-year-old obese female who was hit by a large station wagon. We call them sumos here. It's a company. The company's name is Sumo, and arrived in a town on an open van, and from that van had to travel by 250 kilometers to reach our center by various ambulances over 2 days on very bad roads. And she came with a closed right femoral fracture, an open tibial plateau fracture, admitted on the ward. And we had planned to take her for surgery on day 4 because she was apparently okay, but her biological reserve was holding up, then it did not. And when we took her to theater, we realized that she had a low O2 saturation, there was tachycardia. So we sent her back, and then she developed a full-blown ARDS. Possibly there could have been a fat embolism, there was a full lung whiteout. So she recovered in ITU, and then on day 12, we took her and we put a nail in the femur, we plated her tibia, and then we again sent her back to intensive care. And on day 14, a soft tissue coverage was done by which a flap was done. And then again, we waited, and then she recovered a little bit. On day 16, we started allowing her to sit up and stand up a little bit with a walker. You can see here the pictures, and she was doing fine. But as you can see here, the strategies which we employed were directed at early mobilization. But there was, because we allowed very early weight bearing, we have a little problem with the pain. I'll show you in the next X-ray. But this was able to boost her morale and boost the morale of her father, who was really, in tears every single day I met him after having seen the daughter through a near-death experience. So we felt that if we can get her to sit and stand, it would convince her and her parents that she was going to live. Now, this lady, she had all her metal taken out, and she works for a software company now. She's got married also. But there was a little bit of collapse, as you can see from the tibia, because we did not have a chance to put bone graft in the emergency situation. So we offered her a surgery to straighten out the tibia, but she said she is fine. And she said that she doesn't want to have any further surgery. So I leave you with my final thoughts that philosophers have only interpreted the world in many ways. The point, however, is to change it. And this is from Karl Marx. This is not a political statement, but I think it's an important statement in the sense that we should not let the low resources we have in our countries determine what we are going to do. We should have our own system. We should have our own plan. We should try and improve our infrastructure. We are not philosophers. We are ultimately surgeons. We are the doers of the medical community. And the only way to improve outcomes in a sustainable way is to actually improve your physical infrastructure and your medical knowledge. So these are the things you need to do. You need to have proper tools. You need to have, you can see over here, this is an Indian system which is quite cheap, where you can use an indigenous saw, or you have drills. These are much cheaper than what you would buy from foreign companies. Then all these tables, these are all manufactured in India, much cheaper. And we have various tourniquets which are also cheaper. And so we have been able to cut the cost. We don't buy from international companies unless we have to. And of course, don't forget the people who work with you, those who work for you and for your hospital. This is our team of technicians, all bright young men. This gentleman in particular, he's my right hand, and he has trained them all. And at the end of the day, it is people who determine what outcome you have. And it's very important that you just don't focus on equipment, but also the people working with you, your juniors, your co-workers, your anesthetists, your paramedics, everything. Thank you very much.